On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, including recent regulatory changes in Kentucky related to medical errors, a discussion about a recent survey and governing body reporting of QAPI activities, and in our focus segment, we talk about managing drug costs with John Karwoski with JDJ Consulting.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 223 of the ASC Podcast with John Goehle for June 9th, 2024, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and Operations Manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. And joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
And as we're recording this episode, we're in the studio, but there's a serious thunderstorm going on outside. Yep. I don't think our microphones will pick that up, but if we suddenly if we suddenly get startled, that's probably what's going on. So we had a lot going on in the last couple of weeks here. I was down in New Jersey for their annual conference. It was a great conference. Had a lot of fun. I did a speech about benchmarking down there. Got to meet a lot of great people, and we recorded a special episode, which we posted yesterday, and we interviewed a number of people that I think have a national scope. So we're actually going to use one of those interviews in our focus segment today. So hopefully everybody will enjoy some of the insights that came about from that conference. And Sue, as you know, my car broke down on the way to the conference and ended up having to have a replacement of its transmission. So I'm heading back down to New Jersey later today to pick up my car on Tuesday. But in the meantime, I do have a survey coming up with HHC. I'm actually looking forward to it, Sue. I know I haven't exactly sounded like I was looking forward to it, but this is going to be the first survey using the new software. And the problem is I haven't been able to actually have the training yet on it, but I've been practicing. I've been learning how to use it. And I do have to say, I like what I see. I think the only problem is that I have with change, as you well know.
Yeah. Well, it'll be a big learning curve, it sounds like. There are some different things, but like you said, I've heard you mention a couple of things that you really are feeling.
It's very logical.
Headed in the right direction.
Yeah, it's very logical, and there's a lot of information I can see. What will be different for me, though, is that I like to talk, as everybody knows, and I think that we'll be much more reliant on the computer now than perhaps in the past. I used to, take a lot of notes and then put it into the computer after the survey. I don't think I'm really going to be able to do that with the new software. But I'm looking forward to it. And luckily, this is an organization I'm familiar with because they are part of a management company group. So, but it should be a fun time. But I'll report back on how smoothly everything went afterwards. We have had a lot of surveys. A lot of our organizations organizations have had surveys lately. And, one of the things, we're going to talk about this a little bit later on, but we're starting to see some more inexperienced surveyors, which has been frustrating for our centers. I think our staff is used to it, but the centers are, they get the brunt of it when an inexperienced surveyor brings something up that's like incorrect. It's one thing for me to say, don't worry, that will never show up in the final report because it won't get past the review process. But it still upsets people. So just be aware that that has been a challenge lately. Surveyors are still learning. Sometimes they say something before they've thoroughly researched it, and so keep an eye out for that. And we have a lot of new surgery centers opening up. We've been called into a number of cases. It's unfortunate, Sue, as you well know, because you helped us schedule these things. But our challenge lately has been we often are brought into the pre-opening survey with very little time left before that survey actually occurs. So if you're thinking about hiring ambulatory healthcare strategies to help you, please give us more time, is what I'm saying. And the other thing I think we always see, too, is that they think that the surgery center is going to be completed on such and such a date. But the reality right now is with construction, with supply chain, it's been very different. And we are continuing to have our wonderful drop-in sessions on Saturday mornings. It's been down a little bit. You notice that, Sue, the last couple of days? Or last couple of weeks, I think people are enjoying the beginnings, the spring weather, and the beginnings of summer here.
You can take your computer or your phone to the pool. I mean, it's okay.
we have
a priority.
We have a couple people that pop on from the games,
the kids'
soccer games. So, but it is something enjoyable. So, for more information about becoming a patron member, go to ASCPodcast.com or ASC-Central.com.
Yep.
So, Sue, what's going on in the news?
So I saw a couple of articles that I found interesting on basically preventing surgical site infections. So there was a study presented by Science Translational Medicine that was conducted by Dustin R. Long and his team of researchers. They took samples preoperatively from patients' skin, nares, and their stools to allow the researchers to analyze their already existing microbiome in these areas. It was determined that 86% of surgical site infections were caused by the patient's own pre-existing bacteria. There was no evidence of any kind of a common source of infection going between patients. Also, 59% of the bacteria were resistant to the prophylactic antibiotic and antiseptics that are normally administered prior to or during surgery. So this could lead to, I think, a much more effective prevention strategies gearing toward whether you would pre-test, and specifically treat the patient's own specific microbiome. I mean, I think it's in the beginning stages, but it was kind of interesting. And I know we do prep patients, have them wash with certain soaps and that kind of thing. But
sounds like patient education is a very important thing here about, we have to remember, as much as we try to keep ourselves clean, it's much more important as you're coming upon surgery.
Yeah, and the bacteria is not harmful bacteria until it gets into a surgical site.
Yeah.
And the next one has to do with that also about nasal decolonization. And this is from OR Manager from May 24. And they found that at least 70 to 95% of all surgical site infections originate in the microbiome of the patient's own skin and nares. As I said above, nasal decolonization is recommended by AORN and the CDC, as well as some other organizations. The article discussed the most common solutions, which are mupirocin, which is an antibiotic and is pretty commonly used, as well as povidone iodine, which is an antiseptic. And while both of those are effective, there are, of course, pros and cons to each one. And the povidone iodine has the benefit of being an antiseptic, and therefore it's not contributing to microbial resistance, which is an important point. A recent study showed mupirocin can be more effective in the ICU setting, and part of it has to do with how it has to be used. However, mupirocin requires patients' compliance with 5 days of twice-a-day application. So, of course, you may have people that are not following through with that, or of course, in emergency surgeries, you just don't have time to do that. The povidone iodine can be applied immediately pre-op by the facility, and per this article, Duke Raleigh Hospital investigations investigators recently found a 60% reduction in SSIs in patients who had elective orthopedic surgery with the use of a 10% povidone iodine nasal antiseptic agent. So it's important to have this discussion and consider if you should change or update your protocols. And I thought an interesting note in this article is that patients are much more tolerant of having their nostrils swabbed after having the experience with the COVID testing, because they're so used to the experience of testing for COVID, which was much more invasive and could really be painful, that now they're much more open to just a quick little swab, whereas they used to, be a little more resistant to it. So
that's interesting. I think we have to put this in perspective, though, because I'm hoping that we all have relatively low infection rates, SSI rates. But you and I've talked about this before too, Sue, is that we're not always sure that we're getting complete information at the surgery center level, that the doctors might not always be reporting. They might be forgetting to report. The patients might not be, giving that information to us. But I think this is definitely something you should keep in, back of your mind, especially if you do have higher rates, or if you have rates of SSIs that are increasing.
And depending on what you do, the ortho procedures, obviously.
That's right. The higher risk for SSIs. But at the very least, you probably should have this conversation or pass it on to your medical staff for further investigation.
Okay, and the next one, our friends at MedServe sent us a diversion alert article. An ambulatory surgery center in Iowa has been fined $125,000 for violating the Controlled Substance Act. After a nurse was caught diverting fentanyl, the DEA launched an investigation and found the employees were, quote-unquote, batch signing the records, stating that they had witnessed the wasting of the medication while they really, so they would just do a bunch of them at the end of the day.
Without actually
really
observing.
Hadn't witnessed. They just kind of took them in and went through them all. And they had some other poor practices that were found. The ASC also failed to make a timely report to the DEA after they discovered the theft. And according to a press release from the U.S. Department of Justice, the nurse had been tampering with vials of fentanyl by drawing up some of the medication and then refilling it again with saline before placing the vial back into storage.
Yeah, so this is interesting. A fine, if this doesn't scare people, this is we've been talking about this a lot on the podcast, a lot of our interviews. By the way, we do have an interview with a pharmacist this time, but I decided not to focus on this issue. But it was interesting that this just popped up. There's so many other things going on in pharmacy too, like drug costs, which we're going to talk about in our focus segment. But we can't forget about the issue of diversion and how important it is to use your pharmacy consultant when something occurs, so you know what reporting requirements you're going to have to avoid this type of a situation that they got into, and of course to do a thorough investigation to identify the root cause of that diversion. Yeah,
and with this, you wouldn't have noticed any missing vials, so it's important. Again, with the making sure that any wasting is caught, but with this, where she was just taking vials that hadn't been opened yet and refilling them as saline, you would just start noticing patients maybe weren't having the right response to the pain medication. It could have been an infection risk. And so, just finding a way to keep track of who is actually accessing the medications and really paying attention when you are opening them, see if you notice anything. It looks doesn't
on
look
the
right.
vials,
And WKYT in Kentucky reported that Kentucky has been the first state to decriminalize medical errors. This was prompted by the criminal conviction of the nurse from Vanderbilt that I'm sure all heard about.
And talked about on the podcast.
Yes. Of course, the concern with criminalization of medical errors is the effect that it could have on the reporting of errors and on having an effective quality improvement program if the providers are afraid to disclose any mistakes or near misses that might come up. Abe Money, a criminal defense attorney, pointed out that there will still be the ability to bring civil suits, and this also is not meant to protect those who intentionally do harm to patients. It just is going to address the actual mistakes.
And we talked in our last episode, the last non special episode, we talked about quality improvement programs, and it dawns on me, Sue, that we really didn't spend much time in that conference. We really didn't spend much time in the episode, if any time, talking about how important it is to understand that the activities of the quality improvement program are not subject to subpoena in most states, and that you have to protect that. And to that end, we had an interesting situation this last week where we had a surveyor who, when they were reviewing the governing body minutes, actually stated to the organization that they should have attached the minutes of the Quality Improvement Committee to the governing body. And we, of course, pushed back from that, saying that would make that discoverable, or could potentially make that discoverable in the court of law. The surveyor continued to push back on that particular situation. Now, as I usually recommend, we opted, or we suggested that we not push this issue because it's likely that when the surveyor tried to report that in the plan of correct, or in the statement of deficiencies, that their supervisors would catch this error and not allow it to come through. But we are fully prepared to fight this particular citation because, of course, doing attaching those minutes could be quite detrimental to to any legal situation that would occur. There's no lawsuit involved in any of the activities going on here, so this is not really relevant to an actual situation at the surgery center.
But it would be poor practice.
It would be poor practice, exactly. So it did dawn on me that maybe I should just make a couple comments here. We just want to remind people that you really want to have vibrant quality improvement meetings. You can feel free to write things quite appropriately and in detail in the quality improvement minutes. But when you report the activities of the Quality Improvement Committee to the governing body, you don't get specific. You don't talk about individual patients. You don't talk about individual doctors that were involved in something. You talk in generalities as much as possible. I gave the example here. Let's say that you had an issue with patient falls. You might say in the minutes, there were 2 patient falls during the last quarter, and upon the recommendation of the Quality Improvement Committee, the governing body has adopted a new process for identifying fall risk patients. Again, we're not getting any specifics about any of the patients that were involved, the doctors or the nurses that were involved. It's non-judgmental. In this case, and we're kind of closing the loop, as we always like to talk about, closing the loop on this by, saying that, hey, maybe we could do a better job of identifying fall risk patients. Always remember, though, the governing body is responsible for overseeing the quality improvement activities and approving policies. So you have to demonstrate that oversight in the governing body minutes. But it is the results of the reviews that are important, not the individual incidents or other activities of the QI process. So if you do have any more questions about that, I think Sue, you and I would really like some more feedback on whether we should go into more details on that. So if you do have a question or want further clarification, just send us an email at comments@ascpodcast.com, and we might go into a little bit more detail there. So we've also had a situation recently where some physicians have been asking to allow their PAs to actually do some procedures. And it brings up the question of scope of practice in the surgery center. And we have to be very careful in this area. So I do want to call people back to the Condition for Coverage, Medicare Regulation 416.42 about surgical services. And it states this: surgical procedures must be performed in a safe manner by qualified physicians who have been granted clinical privileges by the governing body of the ASC in accordance with approved policies and procedures of the ASC. And the interpretive guidelines for 416.42 goes on to identify what a qualified physician is. Surgery in an ASC may only be performed by a qualified physician. With respect to ASCs, a physician is defined in accordance with a part of the Social Security Act to include a doctor of medicine or osteopathy, a doctor of dental surgery or dental medicine, and a doctor of podiatric medicine. In all cases, the physician must be licensed in the state in which the ASC is located and practicing within their scope of practice under his or her license. So we just have to, kind of point out how dangerous this could be if the physician is allowing the PA to do the procedure itself as opposed to closing the procedure, et cetera. And certainly that even when they're doing the closure or the opening or the incision, whatever part of that might fall under their scope of practice, they need to make sure that the physician is present in the operating room or immediately available. They certainly can't be involved in another case, which is something that's been coming up lately too, is that, physicians have been saying, well, I want to let my had requests from some physicians to allow their PA to finish the procedure for them while they go on to do another procedure. And that, of course, would not be allowed. So just something to keep an eye on. So during the New Jersey Association meeting, I had an opportunity to interview John Karwoski. John is a friend of our podcast. He's been on a number of times, and he did a presentation about drug costs. So I thought that would be a good interview to place here. So why don't we take a short break, and when we come back, we'll have an interview with John Karwoski with JDJ Consulting, where we talk about drug costs. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our administrator boot camp and the director of nursing boot camp, and in 2023, the business office manager boot camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central patron program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. I'm here at the 2024 annual New Jersey State Association meeting in Somerset, New Jersey. And I'm here with my friend, John Karwoski. He's with JDJ Consulting and one of our recommended pharmacy consultants for our centers in the tri-state area in particular. You are all over the country. John, introduce yourself and your company.
Hi, John. Yes, John Karwoski with JDJ. I'm the president and founder. I formed JDJ after leaving a director of pharmacy position in Philadelphia to start this company in 2001. We've grown through the Mid-Atlantic states and currently probably one of the only consultant pharmacy services throughout the country, from California to Florida to New York and everywhere in between. We really like helping centers, whether they're de novo or ongoing or conversion from hospital to surgery centers, on drug safety, regulatory compliance, and cost avoidance.
What I loved about your speech this time is let's put it this way. I think you and I are both tired of talking about drug diversion. We have to talk about it, but we've spent a lot of time talking about it. And we talk about, compliance with regulations. This time you did a speech on pricing and costs. So I thought that would be, I don't think we've ever talked about it on the podcast. So talk a little bit about what you discussed during your conference and anything you have to say about financing drugs.
I was very excited when asked to do the talk, and I knew this talk was what I wanted to do. Cost analysis of drug expenditures in our ASCs. Since 2016, JDJ Consulting has been completing an annual benchmarking study on drug costs in surgery centers, with a few additional questions on new formulary additions, new types of surgical procedures related to drug expenses. And I was able to present that today in a graph fashion that demonstrated what certain drugs used in surgery centers have done since 2016 to the current time. We'll do it again this year as another benchmarking study. And secondly, I've looked at some drugs that were new over that time period, new FDA drugs that were added to formularies in surgery centers. And it was quite interesting with a drug like Exparel. About 50% of centers have added it. IV Tylenol, another drug that was questionable on whether we should add it due to the expense. So I looked at those types of things. We also looked at GI centers and how to manage their drugs, and cataract centers and who's using some compounded intracameral injectable medications. So I think it was really a take-home message for our managers to take a look at their drug formulary. And it always starts with what drugs are approved for your patients in that center. And finally, look at how you're managing your inventory. The talk that you gave this morning was tremendous on the 80-20 rule, or 80% of your costs come from the top 20% of the drugs you buy. And can we inventory turn those drugs over and over so we don't have cash sitting on the shelf?
Right.
Exact message you had with the financials is what I shared with the pharmaceutical costs.
So, John, you brought up something that I think is important to remind our listeners here, is that you do this cost study on an annual basis for your clients. And you also mentioned benchmarking, which is near and dear to me. That type of a study can definitely be used not only to demonstrate compliance with your external benchmarking requirements, but as I talked about quite a bit, as identifying opportunities for identifying ways to cut costs, et cetera.
Yeah. You hit it on the head there with, the requirements for benchmarking for an ASC. Some of my centers have actually used our benchmarking study for their AAAHC surveyor and very well received. And we've done the work. We're doing the work for our clients because we see the value that it could give them in not having to take them away from the care of their patients. So it's really been a win-win with what we've done over the years. And you're right, I don't know of many other pharmacy consultants that are looking at the data, the benchmarking data that we've collected for these number of years. I learned this when I was a director of pharmacy in Philadelphia at a hospital where we looked at drug costs annually through our national organization. And we at JDJ are kind of doing the same things for our surgery centers.
So where do you think drug costs are going right now in the industry, and what's driving some of these prices that we're seeing?
Number one, new FDA-approved drugs are expensive. And they are marketed heavily by a strong sales force to surgeons.
Yeah.
If we cannot control that, the surgery centers cannot afford these new expenses. Even though it's a pass-through in some respects, they don't know when and how to manage it. And surgeons just want. Yeah. So my feelings is an expert pharmacist or someone that can research the data-driven usage of new drugs and put it in a position where we know the drug might be needed for some people, but not every person needs it. And other than that, our generic drugs aren't really moving much. Our data showed us for the last 8 years, John, that we see a little bit of peaks and valleys, but if you're not part of a GPO, you're not taking advantage of the cost savings, so that's number one. Your generic drugs are going to be generic drugs, manage the inventory and not have cash on your shelf. But the new drugs being approved by the FDA, particularly in ophthalmology, orthopedics, your pharmacist needs to be on the table as a decision maker with the physicians.
And keeping control, making sure everybody knows the ramifications of this. You did mention that some are pass-throughs, but let's face it, a lot of the drugs that are under this pressure are not pass-through. And many people in the organization don't even know the pass-through drugs or that they don't communicate with the billing department to find out what they can get passed through. Or, I'm sorry to say it, sometimes the doctors are given misinformation by the drug reps as to what you can get reimbursed for.
It's a sticky world that we put a nursing director in the middle of.
Yeah.
And they've never been trained with this. I mean, I was a chairman of the P&T committee at a hospital for a number of years. It's a complex way to evaluate drugs utilization in a facility, both from an efficacy and a safety and a cost standpoint. I was just talking to a sales rep from the company that makes Exparel in the audience today.
Yeah.
Asking me about, do you know about the reimbursement? Pharmacy's always been a cost center.
Yeah.
All we worried about is how much we spend. Administration and finance and your people can then look at what are we recouping after we send the charges out. But pharmacy, we want to make sure we are not using drugs incorrectly and adding costs to the bottom line of the case.
Right. Where do you think the supply chain issues are heading right now? I know that we've been constrained in the past. Is this problem going away anytime soon?
No. It's like in everything. Supply chain is the heart of getting your just in time drugs.
Right.
What does that affect? Well, that affects managers and buyers stockpiling because they're worried about the supply chain.
Which exacerbates the problem.
Exactly.
Yeah.
It snowballs the cost because, as you know, John, drugs on your shelf are cash that could have been used somewhere else.
Right.
And we put our purchasing agents in surgery centers in a dangerous position. They can't go to a surgeon Monday morning and say, we're out of it, it didn't show up.
Yeah.
So they take more inventory. If you give them shelves, they're going to fill the shelves up.
Right.
So supply chain is going to be supply chain. We just have to help the buyer and the nursing management team know how to look at the high dollar drugs, the 80-20 list, the reorder points so that we don't run out. I did a nice graph on this thing where this danger point, as you run down the inventory amount, is critical. You can't get into the critical part. But you can't get into the overstock part either because who's going to walk into it?
Age out. Yeah.
The CEO is going to knock on your door and say, hey, you're spending this much money and you got this much money on the shelf.
Right, and you risk the drug expiring before you can actually
expiration.
use it.
So I think our buyers are put in a very difficult position in today's world because the supply chain is unpredictable.
Well, and you bring to an important point. You know, I've been a big supporter of pharmacy consultants. You know, many of the states we work in, pharmacy consultants are required, but that's not always the case. So without selling your service, because it's an excellent service, don't get me wrong, but sell the purpose of a pharmacy consultant for our audience.
And we see the different variations in state requirements. Some centers are still, how many times does the rule say I need you?
Yeah.
They don't see the bigger picture. The bigger picture,
or the value of it. They think of the regulatory requirement, but not the value.
Yes, just the regulatory. I've left managers who, when I've done a visit, found infractions, John. I went to the administrator. She said, well, we just had our accreditation and we had zero deficiencies.
Don't get me started.
Now, I don't like that line because that surveyor doesn't have the eyes for everything.
Right.
And the pharmacist is the best one to say, hey, you're reusing your propofol vials more than one patient.
Right. Because they can look at the records where the average surveyor is not getting that level
exactly.
of detail.
So I think the value of a consultant pharmacist is our pharmacists are clinical pharmacists out of hospital practice because we're using acute care medications in the surgery center. Mm-hmm. We're not a retail pharmacy consultant group because I couldn't work at a Walgreens because I don't know Walgreens drugs. I don't know the street drugs. I know the hospital drugs. Right. And I can speak to the anesthesiologists and the surgeons where maybe the director of nursing needs that champion to defend the cost of products.
Yeah, and your point's very well taken. I've walked into places where they're using a retail pharmacist for the consultant. They have no clue what's going on. And you know, I watched an interaction with you and one of your clients just before we came up here, where they were asking for an alternative drug. You gave them a great answer. Those are the things that sometimes our clients don't remember that it could be very valuable. One thing that you and I kind of talked about a little bit before, one of our sponsors is MedServ, which makes this wonderful cabinet and for storage of these drugs, and it's a really great alternative to the very expensive option. I mean, we all love Pyxis; it's a great product, but it's too expensive, to be honest, with the average surgery center. Can you talk? I mean, we can mention MedServ; it is a sponsor, but just talk about where we're heading with regard to drug documentation very quickly, because I know the focus is more on price.
Automate. We're behind the times in automated dispensing cabinets. Pyxis doesn't do anything for a surgery center; it's way too expensive. It doesn't have the need. MedServ and I stumbled upon each other about 5 years ago. They weren't ready for prime time, and I told them they didn't have enough reporting. Today's units are priced competitively. They're going to be able to give us control of narcotics. But you know what we're using them for now, John? We're using them for tracking expensive drug usage.
Oh, good.
So when a doctor wants Sigamadex, which is expensive, they have to put the patient name in and dispense a vial that's linked to their name as they used it.
Yeah.
And it might be some qualifiers on there. You can't do that when you walk into a med cabinet and the drug's on the shelf.
Right.
You're never going to control drugs expenditures if you don't have automation. I can go and bring up my surgery center's reports on my cloud-based data system right now, wherever I'm at, and tell my nursing director, hey, that Sigamadex usage is starting to sneak up. Let's have a meeting.
Right.
And that's automation, John. and we need it in our surgery centers.
Absolutely. You need to be looking at these products now, if for no other reason to remain compliant, with the pharmacy regulations, for documentation. So I think we're going to be talking a lot more about that over the next year. John, it's always a pleasure talking to you. I'm sure I'm going to see you again soon somewhere, some state, but thanks for your time.
Always great to chat. Stay in touch. Have a great Memorial Day weekend.
You too.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So this week, the Gulf States Conference is going to be June 11th through the 13th, 2024, in Biloxi, Mississippi at the Beau Rivage Resort and Casino. I hope I'm pronouncing that properly, by the way.
And Becker's Spine, Orthopedic, and Pain Management-driven ASC Conference is June 19th through the 22nd in Chicago at the Swiss Hotel.
And our Administrators Bootcamp is going to be presented virtually July 16th through the 19th, 2024. And for more information, visit our website at ASC-Central.com.
The Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 17th through the 19th, 2024 in Orlando, Florida at the Signia by Hilton, Orlando Bonnet Creek.
The Texas Ambulatory Surgery Center Society's annual conference is July 24th through the 26th in Galveston, Texas at the San Luis Resort Spa and Conference Center.
The Georgia Society of ASCs and South Carolina ASC Association's joint semi-annual conference and trade show is August 15th and 16th in Hilton Head, South Carolina at the Marriott Hilton Head Resort and Spa.
The 2024 Illinois Association of Ambulatory Surgery Centers annual meeting will be held August 22nd and 23rd at the Crowne Plaza Chicago O'Hare Hotel in Rosemont, Illinois. And I'll be doing a special ASC Administrators workshop. I think it's about 4 hours long there.
The California Ambulatory Surgery Association's annual conference is September 4th through the 6th in Anaheim, California at the Anaheim Marriott.
And we're still working on attending that conference also. And the Tennessee Ambulatory Surgery Center Association's annual conference is September 12th through the 13th in Chattanooga, Tennessee at the Chattanoogan.
And the New York State Association of Ambulatory Surgery Centers annual conference is September 17th and 18th at the Desmond Hotel in Albany, New York.
And AHS will be doing the pre-conference there, where we're going to be presenting 3 additional hours of education in the areas of HIPAA compliance, infection control, and survey preparation. And that's going to be on Monday the 16th.
The Becker's ASC 30th Annual Meeting, the Business and Operations of ASCs, is October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency.
The Washington Ambulatory Surgery Center Association's 2024 Annual Education Conference and Trade Show will be November 7th through the 8th, 2024 at the Tulalip Resort and Spa in Tulalip, Washington. And I'll be speaking about accreditation and provide an update on accreditation trends. And don't forget, we do have on-demand versions of the ASC Director of Nursing, the ASC Administrators Bootcamp, and the ASC Business Office Managers Bootcamp on our sister website at ASC-Central.com. We do want to remind everybody about our patron membership program and our premium access program, all available at ASC-Central.com. The Patron Member Program, which is also known as ASC Central, is the exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And in addition to our regular, usually weekly drop-in Zoom sessions on Saturday mornings with other patron members and the staff of the podcast, we do have additional patron resources, which include some of our virtual conferences, such as the Credentialing Conference, Conditions for Coverage Conference, and the Introduction to Finance and Accounting Conference, is available for no additional charge if you are a member of that patron program. And there's also example policies and procedures, example forms, and our famous fire and disaster drill kits. Membership helps to defray the costs of producing the podcast, including our research staff, travel costs to conferences, equipment costs, and production costs. For more information, again, please visit ASC-Central.com. Thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found the episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you never miss an episode. We would love any feedback about our episode and ideas for future episodes. And please do so by sending an email to comments@ascpodcast.com.
We'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Kelleritis, Jim Masters, Amy Cronkite, Lori Rodricks, Kathy Fode, Donna Macchio, and Christina Norman. We couldn't do it without them.
Yeah, the list seems to get longer and longer as our company grows. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.